Hello everyone, my name is Henry Pinchbeck. I'm the CEO of 3D Lifeprints, and I'm here today to give you an introduction to our webinar, which is entitled Embedded Medical 3D Printing Experiences from the Point of Care. And to start off, I'm going to give you a quick description of what those two terms of art mean. So firstly, medical 3D printing. That's clearly the creation of patient-specific medical devices. And point of care, well, that means putting the creation of those patient-specific devices right inside the hospital, so embedding the service within the hospital. And 3D Lifeprints feel very confident in talking about these two subjects as it's exactly what we do for a living. We set up and run embedded 3D printing facilities within hospitals. There's going to be a Q&A at the end of the session, and feel free to post some questions during the webinar, and we'll try and cover those at the end. We have several speakers from 3D Lifeprints today. Several of our biomedical engineers will be covering their specialist subjects, and also we've invited some of our surgical colleagues along to give you an insight into the use of our services. So when we look at an embedded 3D printing facility at the point of care, we look really at three major categories of products. We look at hardware, which includes the 3D printing hardware, but also some computing hardware, software of various forms, including segmentation software, and lastly, but certainly not least, is some staffing. Now, an experienced biomedical engineer is crucial to the running of an embedded 3D printing facility. At 3D Lifeprints, we have three embedded facilities, one in Liverpool at Alderhay Hospital, one at the Nuffield Orthopaedic Centre, and another in Wrightington Hospital up in the northwest. While those hospitals are specialised, our services are multidisciplinary, so we can deal with any of the kind of cases that come in from those hospitals or the surrounding regions. Now I'm going to pass over to my next speaker, who will take you through the next stage of the webinar. I hope you enjoy it.
Good afternoon. My name's Tom Koska. I'm a consultant orthopaedic oncology surgeon here at one of the 5 national orthopaedic hospitals in England at the Nuffield Orthopaedic Centre, and I'm also Director of Human Anatomy for the University of Oxford. And we've been doing a lot of work with 3D Lifeprints in terms of formatting, designing and printing some of our very complex tumours to aid with their surgical resection. Now, for us in orthopaedic oncology, you'll be aware this is a critical field in terms of obtaining an adequate surgical margin. And what we mean by that is ensuring that along with the tumour, we're able to resect some normal tissue around the tumour, and that ensures that the patient has the best possible chance of disease-free survival. Now, on this slide, you can see some examples of the work that we've been doing. The first 2 slides are examples of tumours located around the pelvis, where you can see the tumour in the dark yellow, and then a safe zone of transition in the lighter yellow, with the white showing the cutting guide to enable us to safely take the tumour out. The lesion on the far right slide is a complex tumour of the radius in a young 20-year-old patient where again the margins were absolutely critical. And I'm exceptionally excited about this technology. I think it has the real opportunity to take design and theory into the operating theatre, and I think will potentially make a huge difference for our patients. It's a very exciting time for us.
Thank you, Tom. My name is Mikey Richard, and I'm the Head of Engineering for 3D Lifeprints. I work closely with Tom Kosker in both a clinical setting at the Nuffield Orthopaedic Centre and in an educational setting at the University of Oxford's Human Anatomy departments. On the left of your screen, you can see one of our detailed anatomical models. The aim of this model was to clearly show the course of the ureters and their arterial blood supply in relation to surrounding female organs of the pelvis. This model has been carefully segmented by one of our engineers from a combination of overlaid CT and MRI imaging to transform the 2D slices into a composite 3D model. The patient-specific imaging is then digitally post-processed by a medical artist to add in the fine anatomical details and further enhance the models. This technique was developed in collaboration with the University of Oxford and is a great example of advanced multi-material 3D printing being used on-site to create high-fidelity anatomical training models, which are then used to supplement cadaveric anatomy training. In the Evelina Children's Hospital, our on-site engineer has collaborated with consultants to address the lack of bespoke pediatric training and simulation models. Over time, this has led to the creation of highly customized simulators to better train NHS staff in procedures such as IV cannulation, jugular vascular access, and infant chest drain insertion. An example of our infant chest drain simulator being used under ultrasound can be seen on the right of your screen. Replaceable tissue mimicking skin, fat, and muscle pads are featured in the infant chest drain simulator, along with a rigid rib cage. These are all important features which allow the user to identify a safe site for the insertion and subsequent removal of an infant chest drain. Finally, this simulator features a pierceable lung, which is filled with either air or fluid to allow the user to train for a variety of scenarios. Thank you all for listening. I now pass you on to our craniomaxillofacial specialist, Kami Ribolzi.
Thanks, Mike. Another interesting use of 3D printing at the point of care is for the creation of patient-specific surgical guides and implants. It begins in the same manner as anatomical models, with the segmentation of the anatomy from CT scans. The biomedical engineer works closely with the surgeon to understand the challenges and goals of the surgery to simulate the procedure virtually. This is the virtual planification stage. In this example, the procedure involved the resection of a part of the right mandible and the reconstruction with a scapular free flap. After the virtual planification is approved by the surgeon, the biomedical engineer proceeds with the design of the patient-specific devices based on the design requirements specified by the surgeon. In this example, a guide was provided to reproduce the resection plane exactly as planned and pre-drill the position of the screws, avoiding the anatomical obstacles such as the infraalveolar nerve and the teeth roots. To secure the scapular flap in position, a reconstruction plate was designed and 3D printed in titanium. All devices were then delivered to the hospital to be sterilized before intraoperative use. I'll now hand over to Satish Prabhu, a consultant oral and maxillofacial surgeon in Oxford, who will speak about his experience with patient-specific devices.
Thank you, Kami. Patient-specific devices have been there for almost a decade, and it has improved over the time. It does have a significant impact on the quality of reconstruction. And it again depends on a good design engineer who is able to understand the variables involved in the complex reconstruction, but also the complexity of the surgery and the anatomy. And that is what is the role of a good design engineer and the surgeon's interaction should be. And I feel the limitation at the moment that we have in 3D printing and custom-made device is the ability to plan the soft tissue, which I think will need some more research and some more planning. The other element is the unpredictability of resection. The size of the tumor might have changed. So all these things are still a factor that needs to improve. In terms of getting a good result, 3D printing and custom-made reconstruction plates do have a role. Like here in this case, we planned a scapular free flap for reconstructing the mandible, and ability to harvest the exact size of the bone will reduce the donor site morbidity. It also reduces the risk of damaging the flap. We are reducing the size of the bone if it is excess. And also the amount of ischemic time is also reduced when you're able to produce a exact size bone for reconstruction. I feel that all bony flaps we should be using 3D printing and virtual planning. And I feel that the cost that is there is well justified, especially if the reconstruction plate that is 3D printed has a long life, then the patients are likely to need, and if it reduces an operation for a fractured plate, even in a small proportion of patients, then it is worth additional cost. And that's what I feel we should be looking in terms of the long-term outcomes. At present, there is no comparative studies to say this, but I'm sure it will be a topic for us to look into in the near future. Thank you.
My name is Henry Wynne Jones. I'm a consultant trauma and orthopaedic surgeon working at Wrightington Hospital in the northwest of England. I've had experience of 3D printing at Wrightington Hospital for 2 or 3 years now, full stop. We're fortunate to have an on-site printing facility that's provided as part of a joint project between Wrightington Hospital and 3D Lifeprints and Depuy Synthesis. We found the service to be extremely useful in the complex elective orthopaedic work that we undertake at Wrightington. My personal practice is mainly revision joint replacement and complex primary joint replacement. We have found that the point of care 3D printing service is particularly useful for planning complicated cases. The turnaround is quick, and there does seem to be a great deal of benefit having the service on site, because it enables close discussion with the engineering expertise in terms of rendering the images and printing them, full stop. Analysis images from particularly from revision arthroplasty is quite complicated, because there are numerous materials with which affect the CT scan, and the decision on which areas bone cement, etc., can be quite challenging, and doing this as a collaborative approach can be very useful in terms of the understanding of the model to be created. There's a number of ways we found it very useful. The first and most simple is to show patients their own anatomy and to explain why a particular plan is preferable to another plan, but also to explain the complexity of the surgery and to give the patient some perspective about what we can realistically achieve. The other thing it's very useful for is simulating surgery, particularly with the operable printed plastics, which, particularly on the pelvic and acetabulum side, create a realistic simulation of the bone. This is useful because the acetabulum can be reamed or drilled, and this is helpful to determine whether standard off-the-shelf components can be used or something more complex. We've also found it extremely useful for creating custom guides for revision surgery, and one area where this has been especially useful is drill guides for removing well-fixed cement further down the femoral canal, and with adapted instrumentation that can be targeted using custom drill guides. The final area we found it really very useful is for surgical simulation and training. We recently ran a course with real inverted commas cases from cases we had done, and senior orthopedic surgeons in training were able to replicate the actual surgery that we had performed using these models, and it was found to be exceedingly valuable. So in summary, the care 3D printing at Wrightington has been a great leap forward in our ability to interpret anatomy, plan surgery, and improve surgical training for complex surgery. It's been a great asset, and one that we would very much like to continue to have.
Hi, my name is Professor Tim Board. I'm an orthopaedic consultant at Wrightington Hospital. We've used the 3D Lifeprints point of care for a couple of years now. It's been fantastic in terms of diagnosis and planning. Particularly, we've used this for the planning of complex primary hip arthroplasty, particularly surgical stimulation of acetabulum to decide level of coverage of the socket and other issues. Also in planning revision, removal of implants and reconstruction. It's also been particularly helpful in diagnosing slightly more unusual conditions such as psoas irritation on arthroplasties. We've also used this in the clinic to discuss cases with patients, and I think this has been really beneficial. We've also used it in femoroacetabular impingement cases from a diagnostic perspective. And again, this has been very helpful in discussing issues with patients. It's been exceptionally useful having an on-site facility. This enables discussion with our engineer and also provides us with a simulation lab with implants and surgical instruments to perform the surgical simulations.
Hi, my name is Nick Turner. I'm the lead biomedical engineer here at 3D Lifeprints, located at Wrightington Orthopaedic Hospital. I would like to talk to you today about the service we provide at point of care. Diagnostics. The versatility of point of care 3D printing gives us the opportunity to create unique solutions for different surgical specialities. For example, to help understand and diagnose impingement between the femur and the pelvis, we can provide a pseudo-cartilage that allows the bone models to articulate around the correct center of rotation. This can then be used to dynamically test the hip joint without causing discomfort to the patient. Or for cases with voids inside the anatomy such as cysts or bone loss, like in revision ACL or PCL reconstruction of the knee, previously drilled tunnels are incorporated into the models, giving the surgeon a 3D map to ensure they are finding good bone for fixation. The pelvis has a complex and irregular geometry, and during acetabular reconstruction, malformations, bone loss and discontinuities further complicate what can be expected on the day of surgery. By providing a model complete with implants and cement, the surgeon is able to have a 360-degree view of the anatomy to make better informed decisions. Simulation. We provide our models to the surgeons in an operable bone-like material so they can perform the intended procedure in the point of care lab. A complex case may require simulation to identify the size of an acetabular cup or the arrangement of bone loss replacement implants such as augments or buttresses. Access to the lab has proved invaluable for the surgeons here at Wrightington Hospital by giving them the opportunity to confront and rehearse complex cases before ever getting into theatre. Training. With the capacity to print multiple copies of a chosen anatomy, we can provide the physical course material for workshops and training sessions to educate at all levels of surgery. As a much more cost-effective method over cadaveric tissue, we can digitally adjust and manipulate the anatomy to best suit the teaching goal or a surgical skill, for example impaction bone grafting or complex acetabular discontinuities. Research and development. Being embedded at point of care means we can meet with the surgeons and discuss innovative ideas to improve surgical outcomes. For example, patient-specific surgical guides that are designed in collaboration with the clinician can be tested with the patient's own printed bone models to simulate and assess the procedural outcome prior to an operation.
Hello, so my name's Ian Hennessy. I'm a consultant paediatric surgeon at Alder H. Jones Hospital and also get to be the Director of Innovation here, which means I'm in charge of bringing in new things and experimenting with new technologies. And one of my favourite areas is additive manufacturing and 3D printing. We started this journey seeing what this technology was capable of about 5 years ago. And we started off in partnership with 3D Lifeprints. We're one of the first companies that were in our innovation hub. And at the time we were looking at how could this be used in preoperative planning, because we thought there was something more to just looking at something in 3 dimensions. There was a lot to be had from touching it and feeling it and using those other senses. And we worked together to really explore what was possible, not just with the form of it, but the materials. And it was a great journey. And we did this in parallel, looking at AR and VR, and to be honest, they kind of fell away a bit. But 3D printing is now, a really thriving part of the preoperative planning process at Alder Hey. And I think it was best exemplified by a tumour that we did recently. And very kindly, the family allowed us to talk about it, because it was such a powerful example of how 3D printing can be used to make a real impact on a child's care. It's a very difficult tumour, a tumour that we weren't sure if we would be able to remove. And to help clarify it, to help gain support from all the different teams in the hospital who would have to collaborate together to remove such an awkward tumour, a really complex print was made, a beautiful print, but it was a print which allowed you to articulate what the problems were, allowed people to gather around it, to touch it and feel it, to figure out, is this possible? And it was a great story, because at the end of the day, we actually, well, not myself, the oncology surgeons managed to get this tumour out, and she's had an absolutely fantastic result from the operation itself. And it was made possible really by making this data into something that was tangible, into something which people could understand when they looked at it, that they could touch and feel was very real. And it became almost more of a communication tool in many ways, between the teams and to the family itself. One of the other areas which has been really interesting to watch 3D printing move is around prototyping. Now, one of the things in Innovation Hub is we do like to touch and feel things, and we'll often have an initial idea and we're not sure if it's going to work. So having the ability to very quickly make something physical, which is something which is tailored to what we need, to be able to work with the 3D printing engineers who are embedded with us in our hospital, to kind of work through these problems by creating a rapid iteration of something physical is, again, really valuable. Just like in the case with the tumour, where we have 3D printing engineers working with medics, working with oncologists and families to come together. The same thing is around ideas. And during the COVID crisis, we had an idea for how can we stop touching the door handles. And we thought, would you be able to adjust an ID badge so that you could not touch the door handle as you went through it? And we worked with 3D Lifeprints and their engineers, and we rapidly created a sequence of prototypes to see if this would work, so we could test it within the hospital and get a look and feel for it. And then after that, we actually changed the process for how we made loads of them. We went to an injection molding process, but that initial rapid prototyping, that was really valuable, because if we'd only had available the process of injection molding, it never would have happened. Because to make an injection mold is very expensive. It takes a long time. You can't quickly iterate it or change it. So for me, as a technology, 3D printing is incredibly conducive to innovation. And that's why I've found it so valuable to have a 3D printing hub embedded within our setup.
Thanks, Ian, for your insights into your experiences at the point of care with 3D printing and with 3D Lifeprints. A quick introduction for myself. My name is Paul Thorringham, and I'm the founder and CTO for 3D Lifeprints. Thank you all for taking the time to join us today for this webinar. We hope you found it informative. We'll now have a short question and answer session. There have been a number of questions asked by participants during the course of the webinar today, and we'll try to answer as many as we can. However, please feel free to email us directly if your question is not answered. I would also appreciate feedback on the webinar, as we're looking to have more in the future on a variety of topics.